talk. Next, we have Dr. Sachin MAHULI, who will be talking to us about one more combined surgery, cataract surgery, Phaco in eyes without the vitreous. Dr. Sachin.
Thank you, Dr. Ilan. I thank Dr. Krishna Prasad Kudlu and Vikram for this session. I also thank organizing committee of AIOS for having this here. So I'll be talking basically on cataract surgery in a case which has undergone vitrectomy. There is no vitreous support. This poses a different set of problems pre-operatively, intraoperatively, and post-operatively. We'll be going through these areas in detail. So what are the preoperative challenges are like to assess the vision? We need to get a prognosis for the patient. So fundus assessment itself will be difficult. Dense cataracts and very high myopes, seeing periphery will be difficult. Biometry poses a different set of problems. Silicone oil in the anterior chamber poses a lot of problem for fundoscopy and other things. In corneal tissues, like especially in cases of trauma, there would be scars and other things which you need to assess preoperatively. Biometry, we always, we have most of these biometers which have a silicone oil mode in it. Depends on the what type of silicone oil is used, 1000 centistrokes or 5000 centistrokes, depends on that. We can use that. We can always do a biometry for both the eyes unless the patient is anisometropic. So pre-operative, before the retinal surgery, always the refraction has to be kept in mind. We should look into the refraction of the patient. If the patient has undergone a buccal surgery, then the eye will be elongated. So we need to understand that also. The elongation may, lead to a 2 diopter shift in the IOL power. Corneal scars will lead to very irregular astigmatism. All these things you have to keep in mind, especially in cases of trauma. Silicone oil filled eyes, always check pre-operative refraction, what patient had before the retinal surgeries. That has to be kept in mind when you're calculating. Most of these IOL power calculations on these either biometer or a conventional A scan gives you a reasonably accurate, but you should always be prepared for a refractive surprise in cases with very high myopia and corneal scars. Special problems for the cataract itself are like the cataract could be leathery hard, especially in oil filled eye, wherein the oil itself induces a lot of cataract to harden up. The pupil may not dilate completely. You need to be prepared for that. Anterior chamber shallowing would be there if in the oil filled eyes in a normal case, or in a very high myope you can have a very deep AC, wherein you have to bend your phaco probe very perpendicularly to get the cataract out. PC plugs are again a problem. Usually these plugs don't tear. I mean, you won't get a rent on table, but these plugs can be very thick, and you need to cut them post IOL implantation. Intraoperative, as I said, the small pupil, you may have to use hooks or rings to just get the pupil dilated. Runaway excess is very common, especially in intumescent cataract, especially in young patients who have oil filled eye. You'll have an intumescent cataract, very common. In older patients, you might face a leathery cataract, which will be very difficult to chop. Getting it like either a direct chop or emulsifying it in different phases of the surgery would be ideal. Post buccal and post vitrectomy, you should always anticipate weak zonules. So your stress on the zonule should be very minimal. And if there is a lens touch intraoperatively, the retina surgeon would indicate that, because especially in young patients, you might have a PC dehiscence and PC plugs. Hypotony is one more thing wherein you have to keep using viscoelastic hypotony, especially in cases of high myopia. After the oil removal, especially you are doing oil removal and the cataract together, then the hypotony would be a bigger challenge. So you need to manage that well. Very tight section is important in such cases. You need to play with the infusion flow in the antechamber, especially if this IUP control, it's well and good, but if it is not, then you have to keep reducing or increasing depending on the shallowing and the fluctuation of the antechamber. Emulsified in the oil, like this case, can lead to a lot of surprises. Completely emulsified oils can lead a different set of challenges. These would have endothelial decompensation, so you should be prepared to manage that. Sometimes the cornea can get very foggy, blurry after the AC wash. So all these things need to be kept in mind when you're doing Phaco itself. Okay, this is a rexis related issues. There will be very poor red glow in post retinal surgery, especially if there is vitreous hemorrhage or a diffuse heme when you're doing. you need to have a good visualization, stay in the capsule. Argentinian flag sign is very common in such cases, especially in young patients who have intermittent cataract. Use scissors, forceps, and stay in the capsule very well. This is just a video in which SOR was planned along with the cataract surgery. If you see, it's a very managing PC plaques, which I wanted to make a point, especially most of the time we may have to use a cutter to cut the central PC, and post-operative YAG caps is an option again. Slides are also not moving now. एक मिनट just hold. Anyway, what I wanted to give you a take-home message is these cases pose a very different set of problems, wherein there is increased inflammation, there is intraoperative problems like PC dehiscence, PC plaques, rhexis running away, anterior chamber fluctuation. All these are very common intraoperative problems. So you have to be very meticulous, slow in your surgery, plan the surgery very well. IOL calculation has to be very adequate, and you achieve a near 6/6 vision in most of these cases, provided you have planned all this very well. Thank you so much.